Hi, everyone, and welcome. What we're going to do here is a little bit of an icebreaker, an opportunity for everyone to join our webinar today. I'm going to get everybody who's on Zoom to use our chat button in the Zoom toolbar and just let me know where you're tuning in from. My name's Troy. I'm the Director of Operations for Nurses Specialized in Wound, Ostomy, and Continence Canada. I'm tuning in from Ottawa, right downtown in Ottawa today, and I'm happy to be joined by a couple of our guests today, and of course our guest speaker, Karen Laforet. And before we get started, I'm just going to do a couple little housekeeping items. Firstly, we are going to be having a question and answer period at the end of this webinar. So what we'll do is get you to use that Q&A button in your Zoom toolbar. You can ask all your questions there. That'll make sure that all of our panelists will be able to see, and we'll make sure to answer those questions towards the end. We're also recording this presentation today, so if you want to go watch it back again or see some of the slides or share this with one of your colleagues, you can definitely do that. It's going to be located on our NSWOCC on our NSWOCC website. And so without further ado, I'm going to introduce this session today, which is called When Two Worlds Collide, Protecting Vascular Access Device Preservation When Skin Integrity is Gone. And we're so delighted to have this presentation supported by our friends at 3M, so that all of this education today is possible due to them. So thank you again, 3M, for the support. So Karen, as I mentioned, is our guest speaker today, and she's a registered nurse with over 40 years of experience, and 30 of those are dedicated to the practice of skin health, medication safety, and infusion therapy. She has practiced in critical care, home care, and long-term care, as well as working for 9 years with 3M and KCI. She's board certified in vascular access and Canadian Vascular Access Association certified, nationally certified in community health nursing, and has a master's degree in clinical science wound healing. She's on faculty for York University's infusion therapy postgraduate courses that she developed, as well as faculty for York's Wound Care Institute. She's currently the lead educator for VHA Healthcare Long-Term Care IV Medication Training Program and on the team of wound consultants for long-term care. Karen is a past Canadian Vascular Access Association board member and currently a board member and past president-elect for the Association of Vascular Access, or AVA, and a board member for the National Coalition for IV Push Safety. So we are in for a treat today. We have an expert with us, so we hope you enjoy this webinar today, and I'll pass over the mic to Karen. Thanks, Karen.
Thanks, Troy. Hi, everyone. Thank you for joining me today. I'm really excited to share my experience on both sides of the fence, one on vascular access as well as wound care. Okay, just behave. Come on, slides, let's go. I always have this problem. There we go. A couple of important things, just so that you know, the slides that, the photos that you're going to be seeing are mine, except where they're otherwise indicated. I am a speaker for 3M, and as you well know, and here's my disclosures. So just to move forward, today we're going to talk about the uniqueness of vascular access devices and the potential for skin damage. Risk factors that are associated with skin breakdown for persons with a vascular access device, or you might also have heard the term IV catheter or IV catheter or a PICC line or a line. Those are the same thing. Dressing selection to meet goals of securement as well as infection control for persons with a vascular access in place. The challenges that we face in securing these devices when patients have damaged skin, as well as different dressing applications that protect. And for some reason thank you, Troy. I guess you're moving that forward. We're going to do a first poll. So have you been asked to do a consult on a patient with a central vascular access device or a CVAD, PICC line, or an IJ, a subclavian, any of those who have had compromised skin integrity? So yes, no, or what is a CVAD?
I'll just leave it open for a couple seconds there. Hopefully you can see it in front of you, Karen, but maybe
yes,
once we get to...
for some reason, my slides are advancing all by themselves. I'm not sure why that is.
Did you want to maybe stop sharing for a second and reshare? Maybe there's something glitching there. In the meantime, what I can do is read you out our percentage here from the poll. So for the first question, we have about 57% of people said yes, 42% or 41% said no, with just a couple percent who are saying, what is a CVAD? So thanks for participating, everybody. I'll let you share in the background there, Karen.
Okay. So let me see, I'll just share again. All right, let's see if this is going to behave itself. Okay, So what is a CVAD? Thank you for those people that asked that question. Vascular access devices, really, why do we have them? We have them because we need to give fluids, blood, medication, fast and efficiently. They absorb very quickly into the bloodstream. And the goal of our therapy when we're putting in an IV is to provide a positive outcome for the patient, ideally painless. We all know that that's not necessarily true. Promote patient comfort and well-being, as well as a complete recovery, and to do so without any complication. A tall order, as we well know. So the CVADs, or central vascular access devices, are really, they're a whole line of different catheters that are used in order to provide all kinds of fluids, especially those that are irritants or vesicants. They do a lot of good work. We see a lot of them in the intensive care units. We see PICC lines, which is one of the central vascular access devices, see them very frequently in the community. And you will hear them in different ways. So I'm sure that you've heard, well, the person has an IJ, or the person has a subclavian, they have a femoral line. Those are actually insertion sites. The catheters that are put there are very different. And so you'll see different variations on what these catheters look like. In this down here, you can see this is an example of a PICC line that I'm sure many of you are very familiar with. In this upper left-hand corner here, this is an example of an implanted device, or a portacath or port that maybe some of you have heard, or subcutaneous port. And so that is buried underneath the skin, and we access it with a needle through the skin. And these are this picture here shows you where the insertion sites generally are located. So in the jugular, the subclavian, in the upper arm. If they have a tunneled catheter, it can be down closer to their waistline, or just on their chest, as you can see here, right here, or in the femoral area. So those locations are what we, unfortunately, a number of people use them as locations as opposed to what the actual device is. But nonetheless, they're central vascular access devices, and that's what we're going to focus on, because these are generally kept in anywhere from, like, your non-tunnel that you'd see in an ICU is usually anywhere from maybe up to 14 days. Your PICC lines can be in for a year, your tunneled catheters and your implanted devices can be in for years as well. So the thing that we want to remember is that every intervention that we do for vascular access device insertion and site maintenance has the potential to affect skin integrity, which is kind of scary when you think about it. So, I'm sure all of you have heard before around the primary focus of a lot of what we do with IVs is to prevent infection, right? And as you can see here with this picture, we've got the hands of the personnel. So of course, high-end hygiene is a big one. We have the insertion of the catheter through the skin. And just to remember that when we insert a catheter, whether it be a peripheral IV or a PICC line, I'll just use PICC line as the example, it's a full thickness wound. It might be a tiny one, but nonetheless, we're going through the epidermis, through into the dermis. And so it is a full thickness wound. The difference is that this wound ends in the bloodstream as opposed to at muscle or bone, right? So that's something that carries with it additional risks that we have to be aware of. And so when we think about this, we use skin antiseptics in order to remove the transient microflora on the skin. Of course, hand hygiene, remove, hopefully the bacteria off of our hands. Once the catheter is inserted, there's a risk of hub contamination or contamination. The hub is where we insert the tubing, where we use syringes to give medication and flush. The dressings, of course, we want to make sure that we remove any of the microbes on the skin. So there's a lot of risk, and a lot of focus has been on infection prevention. And why is that? So this is a bit of a busy chart, but the risk for patients is significant. Essentially, 1 in 3 patients who have a vascular access device will develop a hospital-acquired bacteremia, or what we call a healthcare-acquired bacteremia, simply due to their catheter. And that carries with it at least a 30% mortality rate within the first year for those patients that do develop that infection. The 2 main skin bacteria, so Staph aureus and coag-negative Staphylococcus, are actually on our skin, and this results in about over 60% of those infections of those nosocomial bacteria are caused by our skin bacteria, which is either, of course, due to contamination for a wide variety of reasons. Phlebitis is an important thing to consider because phlebitis is an example of an inflammation / infection that can occur at any time throughout the lifeline of that catheter. So these are all really important considerations that we need to factor in. And when we talk about compromised skin integrity, this is on top of the damage to the skin integrity. So all the work that we want to do is to try to prevent these patients from getting sicker and getting infection, as well as trying to keep the catheter in place for the length of their treatment, if possible. Other vascular access complications that can occur are what we well know as MARSI, so medical adhesive-related skin injuries that can occur at any time whenever we're using an adhesive. Skin breakdown due to products or leaking from the site is another one, and we'll talk about that because that leads to skin damage. Medical device-related pressure injuries is another one. So you can see here in this picture, this catheter was put in less than 24 hours prior to this patient showing up at the clinic. This arrow is pointing to, it's probably hard for you to see, but there's blisters here. So this person basically has a stage 2 medical device-related pressure injury from the hub of the catheter. You can see the imprint of the hub and the extension connector here. So that's a real issue for these patients. When we look at other, like your PICC line, the hub, that nice little triangle, is a very heavy piece of plastic. The catheter itself, once it's in the system, is actually soft. It's kind of like cooked spaghetti. But the hub itself is a very hard plastic and can lead to medical device-related pressure injuries. Our concerns are also around migration or dislodgement of the catheter. If it's not stable and secure enough, it can actually fall out. Had that unfortunately happen way too often. We've talked about contamination and infection. And of course, dressing disruption can lead to all of these other complications. So there's a lot of factors that we have to consider. So when we think about the threats to skin integrity, let's look at, again, we mentioned the interventions needed for vascular access device insertion and site maintenance all have the potential to affect skin integrity. Think of the solvents that we use: adhesive remover, skin tackifier, skin barriers, the friction from the standard of practice of using a hashtag type of friction and scrubbing to help loosen all of that transient microflora from the skin to the surface of the antiseptic. That in itself can, of course, cause skin damage. The antiseptics, alcohol is drying, chlorhexidine is irritating, right? The standard is 2% chlorhexidine with alcohol. So that can be really challenging to the skin. Our adhesives, by nature, are chemical, and also how they're applied and removed is really critical. Each time that dressing is removed, we're removing layers of stratum corneum. It basically is a form of exfoliation, one I would much rather have at a spa than from an adhesive, but nonetheless, when we have a vascular access device in place for long periods of time, we're basically over exfoliating and removing significant layers of stratum corneum, making the skin more vulnerable to injury. And then, of course, the insertion itself, we have to think about, was the insertion traumatic? So if it's done under emergent situations, did they prep the skin properly? Is there bruising? Is there damage to the insertion site so that, I don't know why this keeps advancing, but anyway, I'll just pay attention to that. So that the type of insertion at the time of the insertion is also a threat to skin integrity. So as a refresh, the skin damage cascade, we know that when the stratum corneum is compromised, the skin damage results in increased transepidermal water loss. So the picture on my left here, the healthy skin, you can see that the stratum corneum is like a brick wall. There's nothing getting through. It traps the water. It protects the protective barrier, the skin barrier, right? So we know that that happens. Whenever we have any kind of inflammation or irritation, then what happens is that the inflammation cascade starts. We have a loosening of the gap junctions between the cells so that we have leaking of the water coming from the other layers of the epidermis up through onto the stratum corneum, which causes further irritation and inflammation. So too much moisture, of course, as we know, can lead to loosening of not only the stratum corneum, but that extra transepidermal water loss is also irritating to the skin. So we get this horrible sequela of events that occurs that causes that skin damage. Moisture at the exit site, of course, is really one of the biggest triggers. And so that's why when we think about stability and securement of the catheter, we want to try and reduce the trauma at that exit or insertion site so that we reduce that inflammatory effect. So who's at risk? And, when you look at these, the intrinsic factors, there's not much difference than the patients that we see for wounds and ostomy, right? We know that, those kind of dermatological conditions, patients with comorbidities, photo damage, allergies is one I want you to just keep a flag because we're going to talk about that in a little bit more detail later on. But those are all, it's not a surprise. Patients that are at risk for skin compromise is like for our patients all across the board. When we think about extrinsic risk factors, the ones that are unique for our patients, of course, are those that have prolonged exposure to moisture. Thinking about somebody who has a PICC line in place, they're at home, they take a shower, there's some leakage under their dressing and it stays there for a few days. We can cause significant damage to the skin. We know that moist skin has, what is 5 times more vulnerable to injury than dry skin is. Patients on their medication, that's nothing new that we know about steroids and NSAIDs that can increase the vulnerability of the skin. For our patients with vascular access devices, though, the repeated tape and adhesive applications, as I mentioned already, can cause an overexfoliation that causes the skin to be more vulnerable. And the longer the time the vascular access device is in place, the more vulnerable the skin is. Okay. So these are all good reminders of all of those reasons why our patients are at high risk for skin damage when they have a vascular access device in place. So it's always a good thing to do prevention, and the standards of practice and best practice guidelines for vascular access or IV therapy really talk about 5 key components or elements that help to prevent the loss of skin integrity. So I'll just briefly go over some of these, and then we're going to focus in a little more detail on some of the others. So the right device is really the goal now, as vascular access becomes more of a specialty, is to choose the right device for the patient at the time that they enter the healthcare system. It's a very lofty goal, but it's one that we're working we as the Royal We are working towards to make sure that if the patient needs a PICC line because they have osteomyelitis, then let's make sure they get that PICC line in at the time that they've entered into the healthcare system, not wait 2 or 3 weeks, right? Veins are a finite resource, so the more times we pick them, the more trauma to those veins, and they can develop scar tissue, and then we lose that vein forever. So having the right device at the right time is really important, and the right location. You can see here on the second one from my left that this is actually what you would probably hear in a hospital. This is an IJ. So this is in the person's neck. It's way down low, which is a good spot where we want it. We want the catheter to actually be down against a flat surface of the chest so that we can apply the dressing on a nice, secure, clean surface. We have intact skin there. And you can see here that this is a multi-lumen non-tunneled catheter. So that's the name of it, the generic name. This hub here is our risk factor for medical device-related pressure injuries. And this is a multi-lumen catheter. So there's 3 lumens in this one catheter, and they carry weight. And you can see here they have disinfection caps on them, but otherwise they would usually have tubing. And so historically, they would put the catheter in and have the tails, as we call them, sitting up like this. And so that would pull on the dressing and actually pull and cause skin tears. And also it would disrupt the catheter would actually move. And it's very hard to, especially you can see this person has a beard, trying to adhere something to a beard in a neck fold, and it was really always really difficult. So again, the standard is moved to tails down, use a flat surface, make sure the skin's intact. That right location helps to secure that catheter, keeps it in place, and hopefully promotes skin integrity. I'm going to focus more on the skin protection, securement, and application in the next few slides. So I mentioned before standards of practice and best practice guidelines. The Infusion Nurses Society in the United States has been around for about 50 years, and they developed standards of practice in the early 70s. And every 3 years, they come up with updated standards. And so they're due for a revised version in 2004. But nonetheless, in 2021, their key statement in their standard is anticipate potential risk for skin injury. We've talked about the risk factors. So knowing that our patients are going to be having multiple dressing changes, that our patients are at higher risk, means that we use skin barriers to protect that skin before the skin damage happens. You know, and so all of you are wound ostomy specialists and you're going, yeah, it makes a lot of sense. It does. And unfortunately for IV therapy, the focus has been on the catheter, and again, and not as a criticism, the focus has been on trying to ensure that we don't kill patients because of a bloodstream infection, right? And so now it's around, and there's been lots of shifts, catheters stay in for a much longer time. And so this whole piece on looking at skin protection is really important. So using a sterile, alcohol-free skin barriers is a vital component of protecting the skin. Alcohol is drying, so we don't want something that has alcohol-based. And we want something that hopefully is waterproof, because if there is any kind of leakage, that skin barrier will continue to perform regardless if there's moisture or not. The Canadian Vascular Access Guidelines, so I have both of them from the US as well as Canadian Vascular Access Guidelines, also talks about applying a sterile barrier to skin that is exposed to adhesive. One of the challenges that we're facing is how this need for skin barrier is interpreted. So there's a number of clinicians that believe that the only area that needs to be protected is at the edges of the dressing, because some people have a tendency to stretch the film dressings, but that's not true. We know that any skin that's exposed to adhesive is of course at risk. So we want to cover the whole area of the dressing, but not the exit or the insertion site. Okay, so that's really important. And again, they're very similar. You notice that there's mention about a tackifier, and I'll talk about that a little bit later. It has come back in fashion, if I can use that term, to help secure challenging situations where the adhesives are not sticking due to patient skin conditions, whether it be oily, too much perspiration, those kinds of things. So that's skin protection. The next prevention element, of course, is making sure that we have the right securement. And the securement standards are that we need to have some sort of securement to keep the catheter in place. These are, again, it's floating cooked spaghetti in the vein. They're not secured. And so therefore they are at risk of literally migrating and slipping out. Okay, and so there are securement methods that are to be used in conjunction with the dressing. So those two things together provide that securement and stability of that device. And of course, they're adhesive. So those are things that, of course, increase the risk for skin damage. And so to use those securement devices, and based on the type of catheter that's being used, the patient's age and skin condition, and the integrity, the duration of the therapy, depending upon how long that's going to be in or not, and if there's drainage at the site. So looking at all of those components that are very similar to what we would be looking at when we decide on what kind of wound dressing we want to use. So what am I talking about with securement? So before we go to those methods, I just want to clarify, when we talk about securement and stability, catheter securement is actually a mechanical device that holds that catheter, stops it from actually slipping out. That's what that securement piece is. The stability or the stabilization is really around helping to prevent or significantly reduce these micro movements. So the catheter, because it's sitting in this little opening and floating in the bloodstream, in the vessel, can have little micro twisting motions and micro pistoning motions. And so that irritates and can actually erode the insertion area, or what we call the exit site. You can use either term, same thing. And so that can erode that opening. but it also irritates and can cause damage and erode the vessel itself, because the tip of the catheter is literally kind of going like this or moving up and down and causing irritation against the endothelial wall, which is really, we don't want that to happen. Because as I mentioned, the worst case scenario is it could actually erode through the vessel and cause extravasation or infiltration of the fluid. So when we talk about those methods that work, these are the 4 that are considered, that are within the standards, have been demonstrated to be evidence-based and work. So from my left to my right, starting with transdermal or sutures. Sutures are really not recommended. They're used as an exception rather than the rule. And I know, having had a family member in ICU a couple of weeks ago, they're still using sutures, even though there's other methods that are far better. The pro of using sutures is that it's quick and easy. It does secure, so if you're doing a dressing change, generally the catheter is not going to fall out. However, we know from practice, I know from my experience, that these sutures will actually pop out of the skin. They erode the insertion area because they do not stop piston. Actually, you can literally see sometimes macro pistoning movements of the catheter. So they're an nidus for infection. And they, of course, they require a secondary dressing. So they're not an ideal choice. If anything, it's recommended to move to something else, either one of these other 3 that you see on the screen. The next one is adhesive securement dressing, so ASDs for short. We must have acronyms. We must have acronyms. And the pro of the adhesive securement devices, there's a number of them that are available. 3M has a number of great ones that I'm very glad that they've started, but you can see one here in this corner here. And they have a combination of a securement that actually holds the catheter in place and also stabilizes the dressing so the dressing doesn't lift. They're not intuitive for the most part. You need to have some sort of training. The catheter can be unstable when you're doing a dressing change. Think of something like when you're looking at a PICC line, and of course the PICC line's here. If you haven't stabilized your patient and you're in a good position where that catheter isn't going to like flop around, then that flopping around can actually just, cause catheter migration. That's a whole nother webinar in itself on how to do effective dressing changes, but nonetheless, they do work quite well. They are adhesive. Okay. Your subcutaneous anchor securement device here is actually, it is a metal, almost looks like a little clip. It fits in and goes down into the dermal layer and secures the catheter. We have to be cautious of patients who have autoimmune disorders, because we know that any kind of minor trauma, anything that goes through the skin, can actually trigger pyoderma granulosum or other skin disorders like pemphigus or whatever, so blistering. So we have to be careful about that. They require us, all of these require a secondary dressing unless you have an adhesive securement dressing that is integrated. They're not intuitive as well, so you need to be trained on how to apply them and also remove them. And then the last one, which has gained prominence over the last few years, is tissue adhesive. And tissue adhesive is good as a stabilizer. You can actually apply a little drop right at the insertion site. It helps to reduce bacteria from entering into the system, and it helps to stabilize that catheter to stop those micro movements. And so again, the biggest risk for the tissue adhesive is not removing it properly, so that can result in a skin tear. And because you have it at the actual entrance site or insertion site of the catheter, would erode that wound and make it much bigger. But otherwise, these are your options, and you can use more than one. And all right, so it really depends upon your patient and what's going on. In some cases, you have a choice. In other places, you have what you're given. So that's something that is really depends. I did a presentation recently where a number, like they did not have access to the subcutaneous anchor securement devices at all, and they didn't have access to tissue adhesive. So their 2 choices were sutures or the adhesive securement dressings. And they will work. It's really just around making sure that your policies and procedures fit those securement methods. Dressings, of course, we know we need a sterile dressing. It can be combined or integrated with a securement device. As I talked about, the adhesive securement dressings are similar to that. And transparent dressings are preferred because we can visibly see the insertion site at all times. It's important that we are able to see the catheter pathway. So from the insertion site all the way through where the catheter goes through the vein and at the actual past the tip, so that we can monitor to make sure that there's no infiltration happening, that there's no phlebitis. So that's why film dressings are really good. They mimic the stratum corneum, so they're waterproof, breathable. They're a great option, great invention. Love them. When we have problems with skin integrity and we need something that's more absorbent, there's not the only option that's available from a clear, transparent absorbency perspective is your clear acrylic dressing. Otherwise, what is used is, they call it a gauze dressing. So prior to all of these advanced wound care products like foam dressings and stuff like that, our two options for IV dressings was a film dressing or literally a gauze and tape. So those were our two options. So the gauze dressing is really that a catch-all for any dressing that's not transparent. Okay. And it's important that when we're looking at these dressings, and to just kind of park that in the back of your mind, because when you think about dressing choices, when we have damaged skin, we need to be able to palpate. So one of the standards is really to look, feel, and ask. So to look at the insertion site, to be able to palpate around the insertion site, because of course we're palpating just like we would around the wound edge. We're looking at induration, changes in heat, those kinds of things, erythema, so those non-visible changes that occur in the skin. So we want to be able to palpate. It also helps us to identify if there's early infiltration or phlebitis, because as we palpate, if it's tender, we know that there's a problem there. So when we have an opaque dressing, then of course that site is obscured. So we need to be able to see, ideally be able to see the insertion site. And so that's why when we look at what do we choose, whenever we can, when there's no drainage, is a film dressing. So just to kind of show you, and I don't know why this continues to go on its own, but anyway, we'll just work with it. So when we talk about vascular access assessment, you can see here in this picture that we have, this is the insertion site here. And you can see that we're following the pathway of the catheter past. So this catheter is probably a 20. So the actual tip is just slightly obscured by this border. But then we're going to look at the pathway past here, so that we're looking past where the end of the catheter tip is, so that we can observe what's going on. Okay, we look at the skin under the dressing integrity as well. Is the catheter stable? So is it moving or not? So with everything else, and anytime we have a dressing, if it's loose soiled or damp, we want to definitely change it. And we would do the same thing for vascular access device. And so when we have skin impairment, so these are the things that we're getting into our nitty gritty now. When we look at the skin impairment, what do? Do we put an adhesive on the skin? Now, if they didn't have a vascular access device, would we be putting an adhesive on here? More than likely, no. We'd be doing something else to protect that skin. So let's look at a case study to see what are some options we can do. So EG is a 35-year-old female, has Crohn's disease. The Crohn's disease has been receiving long-term antibiotics for recurrent infection in her leg wound. And she was referred because of a skin irritation under the IV dressing. So prior to her last dressing, she had a little bit of erythemic areas, a few small lesions. This is what we saw when we took off the dressing. So I'm not sure if it's easy to see or not. We have some blistering along the edges. You can see where the dressing actually sat. Right around here, we have some blistering close to the insertion area. It looks almost like a bit of hypergranulation at the insertion site. So this is a bit of a mess. Okay. So we'll go to our next poll question, and that question is, what is your assessment? What do you think is going on? Do you think that there's an allergy to the dressing material, allergy to skin antiseptic, improper drying time, all of the above, none of the above?
Perfect. And we'll just give it a couple more seconds. I know there's a lot to
Oh my
consider
gosh.
there. Oh, no.
I don't know why this keeps advancing, Troy. I
That's
don't have
okay.
any transitions, so.
That's okay. Well, we'll work with it. It's been going well
Okay.
so far. Thanks for putting up. I know technology can be annoying sometimes there. Looks like we've got about 60% of everybody have participated now, so maybe we'll share it just so you can see the responses.
Okay. And so the responses, oh, great. We have 6% for allergy, 6% for allergy to skin antiseptic and dressing material, 12% improper drying time, 73% say all of the above, and 3% say none of the above. Cool. Good. It's difficult to identify, right? So what do we think is happening? Who knows? And that's always our biggest challenge. Is it allergic or irritant dermatitis? Is it something completely different? We do know that inflammation, and any inflammation is always the first mechanism in any type of immune response, whether it be due to trauma or autoimmune disorder. And so how do we tell the difference? And it's very difficult because when you're thinking about, I talked earlier about all the threats to skin integrity, we're using an antiseptic, we're using a skin barrier, we're using an adhesive. The person has something has a catheter going through the epidermis and dermis into the bloodstream. We've got lots of stuff going on in this little wee area. And so when we think about that, it's around assumptions versus facts. And so what we're seeing in the vasculitis community is patients are being told that they're allergic to chlorhexidine, that they're allergic to the skin barrier, they're allergic to the film dressing. I've had one say, I'm allergic to every silicone foam dressing. And I'm like, wow, okay. But none of these have been confirmed by either dermatology or by an allergist, right? So we have to look at assumptions versus facts. And I give you this example here. So this is a composite, it's not the actual reality. This is a 35-year-old woman developed endocarditis and is scheduled to receive 6 weeks of antibiotic therapy. It's ceftriaxone, so she's going to get a midline in place. You can see here in the left, she had a little bit of a reaction after the EKG electrode application. That's not unusual, right? So if there's a bit of redness, usually we expect that it'll go away within 15 to 20 minutes. 2 hours later, this person now has, and I'm not sure if you can see, but you can see the satellite lesions here. So this was the electrode, and now we've got this extended erythema, we've got blistering, quite painful for this person. And then, of course, had their midline put in, and then after their first dressing, you can see, hopefully you can see, it might be difficult, but we've got this erythema in the actual shape of the dressing. And so, is it an allergic reaction? It could be very well be. This person has very sensitive skin. Again, the chest might be sensitive. One of the things I mentioned earlier about thinking about allergies, when you ask people about allergies, ask the question with regards to, have they had any reactions to dressings? Have they had any, and one of the things, and this is from my experience, which is an N of 1, but nonetheless made me think about things a bit differently. A person was wearing a night guard, and I don't even know how we brought it up. I think it was because we were looking at different dressings for them, and they said, it's really weird. I can't wear a night guard anymore because I keep reacting to them. And the dentist or periodontist said, maybe you need to be assessed for an allergy to acrylates. Well, guess what's in most adhesives is acrylate, right? So this person had a very unique, and sure enough, this person did have an acrylate allergy, which you can't wear night guards because it's like that's one of the components. But nonetheless, you know, so something in this, is this woman allergic to acrylates, or is there something else going on? But we need to think about allergies and differentiate, and that's way beyond our scope to be able to say that you have an allergy. But it is enough for us to say, we need to explore this. Patients can develop a sensitivity to any of the components that we're using. So you think about somebody who has a vascular access device, like has a PICC line in place for 6-8 months. We're dealing with this one little area of skin. They're getting the same products over and over again, so they can be sensitized to that. If we give their skin a break and do something else, and then we can go back to those products, and generally they will not have any more reaction. They just, sometimes the body needs a break from stuff. So that's different than an actual allergic dermatitis. So this could be an irritant contact dermatitis. It works out for a lot of patients, about 80% of them. I don't know why I keep doing this. We get an inflammatory response. We get skin reaction limited to the point of contact. So like we could see with this person that we had here, it's limited to the point of contact. Is it allergic or not? This person would need to be checked out. We could do a patch test to see if that makes a difference or not. Okay. And then of course the other one is allergic dermatitis, and that's a very small percentage of the population. And in those cases, we need to identify what that trigger is, whether it be the adhesive, skin barrier, or skin antiseptic. So when we see these kind of reactions, it really is important that we try to identify the cause. At the same time, we know that we still have to manage the vascular access device. We still have to make sure that we reduce further trauma and skin damage. We've got to keep the line in place. If there's exudate, if there's leakage because of the inflammation, we have to manage that. We have to prevent infection, and of course, at the same time, restore the skin barrier. Lots to do. You can see here in this particular patient, the very diffuse irritation. There was a dressing at this point that was this big, and it almost looks like a chemical burn. I don't know if you can tell, it's very diffuse, but nonetheless, this person definitely had a reaction to something that was put on. And then they identified, sorry, I don't know why this keeps doing this. They identified that this person had an actual chlorhexidine allergy. So those things can happen. But nonetheless, when we think about our patients who have compromised skin with a vascular access in place, these are the key components that we want to consider. So, and we also have to consider securement, because when you have something like EG up here, where you also have trauma at the actual insertion site, and we don't want to use adhesive, what are the potential options for us to consider, right? And so before we look at those, I just want to just point specifically that as NSWOCCs, you are in a valuable position to assess dressing application and removal in a way that other nurses may not, those that are very focused on vascular access dressings and the protocols that are required. You can assess that skin integrity, look at what's appropriate for the skin. The challenge, though, is when I mentioned earlier about tackifiers, they have gained prominence because they've now become a default in a number of settings, because the concern is that the dressing will not adhere. And so they just use a tackifier on the edges of the dressing and thinking that it'll stick. The tackifiers also carry with them you know, a risk as well. And we need to assess the practice. If we are adding securement options onto poor practice, we are actually increasing our patient's risk of further skin damage. If they're not allowing the antiseptic to dry and then the skin barrier to dry, and we put the adhesive on, we all know, we've all seen chemical burns because of that. And so putting a tackifier on that kind of bad practice would just cause horrific skin damage, right? So it's important that before we do other things, that we assess to make sure that that we have the right principles in place, that we're using, you know, putting it on clean and dry skin, that we're allowing the products to dry and applying the products properly. Okay. So securement when you have compromised skin. Think about the tissue adhesive as an option because that will stabilize the that'll stabilize the catheter at the insertion site. And it's while it is an adhesive, it's a very small amount and has again, as long as we're using it properly, it is an option. You could also use something like hydrophilic polymer or potassium ferrite powder. Again, this is a good stopgap for 1 or 2 days as a way to help keep that site, the catheter at the insertion site without moving, or you could use the subcutaneous securement device, as you can see here, as an option. Okay, so those are alternatives to adhesive. In EG's case, so what they did was they cleaned the skin with sterile water. They applied a skin barrier, and I'm not sure which one was used. They used a silicone adhesive dressing with an adhesive securement device that had been used before because that's what they had been using. And then 2 days later, we were caught, whoops, oh dear, sorry. We were called because this is what was under the dressing. Okay, so quite horrific wounds. You can see that they've extended, they're quite angry looking. And so we'll go to our next poll to ask you, oh geez, I don't know why this is, I can't fly, there you go. Okay, poll question. What do you suspect is the cause of EG's continued skin breakdown? So we've got, is there improper dressing choice, improper application or removal of the dressing, allergic dermatitis, medication-related adverse reaction, autoimmune response, all of the above, or none of the above?
Alrighty, and hopefully people can see it here. I'll don't see too many answers here, so maybe I'll try resharing it again.
Okay.
Oops. Let's try relaunching the poll here. Okay, hopefully you can see it in front of you now. Sorry about that, everyone.
Zoom is not our friend tonight. I don't know.
That's all right. Now we're getting all the responses all at one time. Perfect.
Okay, there we go. Alrighty.
All right. We'll wait till we get to maybe 50% or so. Awesome. And
Okay.
I'll share the results with you now. You should see it in front of you.
Okay, so we have 43% say all of the above, 26% think it's an autoimmune response, 2% medication-related adverse response, 20% allergic dermatitis, 8% improper application or removal of dressing, and 2% said improper dressing choice. It could very well be a combination of all of those. The challenges many face as far as options for vascular access devices. You know, people are told thou shalt use this antiseptic regardless, thou shalt use this dressing. And so that critical thinking when things are not the usual can be very challenging for some people who don't have that breadth of knowledge. And that's where NSWOCCs come in and would be very helpful. So, and let's see if I can advance this without it going crazy. Ah, right. So in EG's case, Crohn's disease, right, they're at higher risk of pyoderma granulosum. And in her case, that was the issue. Okay, and the skin trauma of putting adhesive onto, so initially she had erythema and some, you know, some minor skin irritation. And rather than identifying that early and being proactive and trying to reduce that trauma, this is what happened. And so it just escalated to a very significant situation. And so I just wanted to put, just to remind that inflammatory diseases, especially autoimmune disorders like your pemphigus, pemphigoid conditions, Crohn's, are at risk for pyoderma granulosum or similar skin disorders like you see here. We had this one situation with this patient where, again, came in, didn't even know what was going on. This, you can see the blisters forming here from a silicone adhesive dressing. And then the next day, this was the condition of the skin. This person was diagnosed later on as having pemphigus. But nonetheless, you know, when we see these weird and wonky wounds, this is where your experience and expertise is valuable to help identify, you know what, there's something else going on here than just something like a sensitivity to chlorhexidine. Okay. So the question is, when you have something like EG and you have compromised skin integrity, do you keep the line in place? Do you replace the line? What do you do? And earlier I'd mentioned about vessel health preservation, and really I know this is a long explanation, but bottom line is that our veins are a finite resource. We want to make sure that we preserve them as much as possible. And rather than removing the catheter if we don't have to, and as long as there's no infection or catheter-related bloodstream infection, they want to try and keep that line in and keep it patent so that we don't have to traumatize the person and start another line. And in the case of EG, she did not want another line put in because she had already had multiple lines. And so as long as we can preserve that, that's our goal, is to try and keep the right device in for the length of the treatment, if at all possible. And so for EG, I just wanted to note that we used what we had available in our little, you know, travel kit. And in this case, there was tissue adhesive. So starting from the left, we put tissue adhesive at the insertion site because the catheter had migrated just about just a little bit over a centimeter. We used a wound contact layer with silver in it. So we fenestrated it and put it around. And then because there was a fair amount of drainage, we used a hydroconductive absorbent dressing on there, and again marked where you can see that little line there, that's where the insertion site is. And then we took a self-adherent wrap, used it in a figure-8 configuration, and then covered it with a stretch cover. EG was very adamant that she wanted to keep that line in, and so was very committed to making sure that she would not shower. She would keep that and monitor it with her life to make sure that nothing was moving. One of the things that is contraindicated in the standards of practice, Infusion Nurse Society standards of practice, is the not using conforming bandages like Cling or Coban around a PICC line because of the risk of causing a tourniquet effect or compression effect, which we don't want to be using. So you noticed in this case, I used a self-adherent wrap, the Easy Fix, if I can use that generic term, that brand name, in a figure-8 loosely, and then we used the stretch bandage to hold that in place. Some practices that I have pulled from ISTAP for skin tears works very well in this situation. So looking at using non-adhesive skin contact layers and site cover dressings. Antimicrobial dressings are fantastic because, again, we've got a break in the skin. We're down from the, again, where it's a partial thickness wound, we're in the dermal layer. We've got our resident microbes that can be bubbling up to the surface. So using an antimicrobial contact layer helps to manage and provide the antimicrobial effect to reduce the risk of bacteria invasion, right? And also protects the insertion site. I'm using skin barriers like Cavalon Advanced, which you can use on damaged skin to act as a skin protectant, is really important. You can see here marking with an arrow the direction to remove the dressing, because where people are used to seeing the insertion site and having all kinds of visibility on where the catheter is, we generally will remove the dressing from so if it's a PICC line, we remove the dressing from the direction towards the head as opposed to the direction down, because again, we don't want to accidentally cause catheter migration. So making sure that if you have an opaque dressing, putting how to remove the dressing. And also you can see here starring where the insertion site is so that you can palpate. And then if you're going to use film rolls, making sure that we don't put anything in a spiral position to cause any kind of tourniquet effect. And then when removing dressings, if you're using silicone adhesive dressings, you want to make sure that you use sterile saline, or you can use the sterile water soluble lube, those little packets, they're sterile, that we use for inserting Foley catheters. applying those to the edges of your silicone adhesive dressings actually works really well in helping to loosen it so that we don't run the risk of the catheter being stuck to the silicone adhesive. I just wanted to show you, this is an example here. This is actually a suture. You can see it's being pulled here on the right because it's stuck on the adhesive. So using saline works really well. Having them remove it from a side position also works. And I just wanted to highlight this poor little tyke here is a neonate, and the insertion of the PICC line caused a pyoderogranulocin lesion. So it can happen to a lot of people. So back to here, the other thing, if you can really reinforce with your clinicians, is that it will take a longer time to remove these dressings, to be very cautious and careful when we're removing them, because again, they don't have that same kind of visibility. Clinical pearls, just a couple of other things that we know this as NSWOCCs and wound specialists. We know that we don't want to be putting dressings on damaged skin, adhesives on damaged skin. So making sure that the dressing fits the need. So you can see two cases here. We've got some erythema happening, and we have this tiny dressing, which isn't going to do much, right? We want something that's going to fit over all of the damaged skin. Same here, you can see how much all this excoriation up at the top, and the dressing kind of ended here. So ideally we would want something larger. You can see how they used silicone adhesive dressing and then cut it out, so you can either, slit it and fenestrate or make a little circle so that you can have visibility to the site. This is a chlorhexidine patch that is prominently used in the US. We don't use those very well. A chlorhexidine gel pad would work much better because you can see through it, and then you could use that in conjunction with a foam dressing, which would work really well. How am I doing for time? Good. Okay, I've got 5 minutes. All right. So another case study. Whoops. Oh my gosh. All right. So this is one that was shared with me on a chat, and I'm just going to kind of show you some of the challenges that clinicians who are vascular access specialists face, and where your expertise would be so valuable to prevent a lot of what happened with this poor 10-year-old. So had PICC insertions before, so I had 4 previous lines because had catheter-related bloodstream infections, and so they replaced it. So this was their 5th line. Definitely has skin allergies to a number of the products, although these skin allergies were not confirmed. They were just identified as skin allergies because of skin reactions. You can see this skin here. You've got blistering, you've got lots of dried exudate. The insertion site looks traumatized. It looks like it's got a bit of purulence here. Surprisingly, there was no bloodstream infection at this point. They tried all kinds of different products, and they were changing the dressing every 2 days, much to this poor tyke's anxiety and pain because this was so painful. This is an example of that subcutaneous securement device that's used. And what they were using on this skin that is broken, they were using betadine, not without any friction, and then removing it with saline soap gauze. So that's kind of what they were doing. So I'm going to ask you a couple of questions. What skin antiseptic would you recommend when you see that kind of wound? Oh my gosh, it moved again. Troy, I'm not sure if it showed or not.
Yep, we've got the poll going there. They're coming in.
Okay,
We'll give
all right,
another,
okay.
just another
So,
few more seconds.
Great. So the skin antiseptic, would you use sterile water, sterile saline, hypochlorous acid solution, avoiding the insertion site, betadine, chlorhexidine 0.5% plus 70% alcohol, oxetine, dihydrochloride, and you're not sure. Which one would you use on that type skin? And stop moving. My slides are possessed. That's it.
No worries. We had about 65% participate, so you should be able to see all the responses in front of you there.
All right. So sterile saline and sterile water are like neck and neck. Hypochlorous acid about 10%, betadine about 17%, and 10% said you're not sure. And that's, it's a real balance to balance the need of the microflora, right? So reduce the transient and resident microflora that's coming up from from the wounds, and also protecting the insertion site. And we know from a wound cleanser that there's a number of different options available, but there's more research is needed to move from the CDC and standards of practice recommendations for either alcohol, chlorhexidine, or betadine as the antiseptics. But we also have to keep in mind that this is for intact skin and it's for reducing the transient microflora. So when in doubt, my recommendation, what I use in my experience in my practice, is I would use sterile saline, and then I would use an antimicrobial contact layer as a way to help manage the microbes that are on the skin, because those are the safest ways of being able to manage that. So we have one more poll question, and this one is, what dressing regime would you recommend for this person, for this 10-year-old? And we have hydrocolloid skin barrier with a window for the VAD site, apply the film dressing to secure and stabilize, an antimicrobial wound contact layer that with the window cut out, non-adhesive foam secure with self-adherent wrap, non-adhesive dressing secured with self-adherent wrap. I need more information regarding sensitivities before making a recommendation. What do people think?
And I'll show you the responses now.
Okay.
Should be able to see them.
And so we have hydrocolloid skin barrier with window, 5%, antimicrobial wound contact layer, fenestrated or window cutout, non-adhesive foam secure with self-adherent wrap or similar, seems to have 54%. And then the next one is, I need more information regarding sensitivities before making a decision. All great choices. Again, it's a real challenge. It really is based on your patient. The antimicrobial wound contact layer with a window cutout, non-adhesive foam works well because, again, we're minimizing the adhesive, and that's always a good choice. And definitely you want to make sure that you're looking at sensitivities. So those two combined would be my best choice. What they did, as you can see here, is they removed that subcutaneous, that orange securement device. They removed that. They put a chlorhexidine patch here. They used hydrocolloid patches and then put the film on top. Not ideal, but this is what they did. Surprisingly, it worked. They were able to reduce the dressing frequency. They were able to get the skin damage under control, surprisingly, because they left the hydrocolloids in place. So reduce that kind of trauma. Again, what they do, you can see that they're thin so that they could palpate the insertion site. The team made the decision to reduce the frequency of dressing changes so long as they were able to meet certain clinical indicators, such as being able to palpate, looking for pain, any kind of bogginess, again, checking the catheter pathway best they could. So there isn't any tried and true situation that we can look at, but at least these are principles that we want to look forward to. So I'm just going to, because I just realized that I'm way ahead, and I'm just going to have to move this one, sorry. So just reminders for your clinicians is that, and we talked about this already, clean and dry. Skin has to be clean and dry, it needs to be intact. We want to make sure that the products that we're applying, any liquid products, need to be completely visibly dry before we put something else on there. Always use a skin barrier unless you're only doing the dressing, like if you have like a 6-hour IV and it's a one-time thing. But if you need to change the dressing at least once, a skin barrier is the way to go. Okay, and so I'm going to, so just as a summary, today we talked about understanding the uniqueness of vascular access devices and know that all interventions fundamental to vascular access device insertion and the care and maintenance have potentials to affect skin integrity. We know that risk factors for persons with vascular access device include things like repeated dressing changes, the type of device, patient comorbidities, and of course, all the stuff that we're using on the skin increases the risk of complications. The dressing selection to meet the goals of securement and infection need to meet the standards and guidelines these are evidence-based recommendations, at the same time following those principles of practice to preserve the device as well as reduce the risk of infection and also restore the skin barrier. NSWOCC scope of practice is really valuable for the interdisciplinary team for prevention, early recognition, and treatment for compromised skin integrity. I encourage you to start doing, if you can, to do education sessions in your workplace to talk about how we can assess skin sooner when we have patients with long-term vascular access devices, so that we can prevent situations like that 10-year-old that we saw, as well as EG. And of course, the importance of understanding threats to skin integrity, proper application, and this is where you also will shine, to proper application removal of products and proper selection of products as well. Okay.
Fantastic.
Thank you.
Well, that was awesome. And I love that we did a couple different case studies there. And thank you to everybody in the audience here for participating. We always love when it's a little bit interactive like that. But again, seriously, thank you to yourself, and thank you again to 3M for going through this. I know we're just a little bit over time, but I would hate to skip Q&A. Do you mind if I just ask 1 or 2 questions? Do you have some time?
I have time. I'm here. Yep. People want to stay. I'm happy. Yep.
Perfect. Well, I know we had quite a few people who were in the audience who work in acute care and hospital here, and one person was just asking about what is the process in doing a patch test? Now, this is going back to some of your earlier slides before the second case study there. In a hospital setting, do you recommend partnering with derm or allergy when doing a patch test?
And if you have access to them, that would be fantastic. You could also, again, some places have procedures for that where you can, or policy that you can do like what I call a quick and easy patch test, if, where you just apply the product on clean skin and then cover it and then monitor it. But if you have access to derm and or an allergist, especially if you're in a teaching hospital, that's a great way to get them involved to be able to identify any kind of allergies.
Perfect. Well, thank you for addressing this. And I know Sukana here is mentioning, I know you mentioned in the chat, but also asking the question about the recommendation of using adhesive remover in patients with fragile or compromised skin. Do you have any thoughts on the use of adhesive removers?
Absolutely. Didn't even think about that. I was looking at compromised skin, but adhesive removers work well. The challenge with adhesive removers with your with securing it, reapplying a dressing, is you have to remove all of that oil. So that becomes like a friction source. When you have compromised skin, it's a challenge, which is why I recommend something like saline or that sterile water lubricant, because it works really well. It is sterile and it's easier to wipe off easily without trying to cause any more friction on the skin.
Thank you. And Stephanie's just mentioning, what about disinfection with VASH hyperchlorous acid? Is that something you could comment on potentially?
Well, I've been in discussion with the company because we don't have anything, and there's nothing in the recommendations, the standards of practice, or in the guidelines for anything other than those skin antiseptics that we know that have been approved. So, that's something that I'm hoping that the company will be able to look at to try and get some sort of indication for that. I know we use it in for wound care a lot. It's fantastic, and it might be a good option for when we have broken skin.
Perfect, thank you. And Xavier here is a PICC nurse, or a peripherally inserted central catheter nurse here. Is there something that they could do to prevent some of these reactions from happening initially?
Good question, Xavier. I'm going back to those 5 elements where, right device, right location, skin protectant, choosing the right securement device, as well as the dressings as well. And, doing that assessment piece when we look at location and device is, since you're putting in PICC lines, is this the most appropriate for the patient? Do they have allergies? What other options would be available? So and I think as a PICC nurse, being able to support the staff who are going to be doing those dressings on a regular basis to really ensure that they understand the significance of how we apply and remove those dressings and keep them in place. And if you're using something like an adhesive securement device, so something like when the 3M PIC securement dressing, all of those, or stat lock is another example of those securement devices. Sorry, 3M, I had to throw that in there. But those have to be changed when you change your dressing. Now, there is some work being done on, do we have to continue to do that dressing change every 7 days, or can we extend it? Because in pediatrics and neonates, those dressings are only changed when they must be changed. So because they are so vulnerable to not only skin trauma, but also that the loss of the catheter would be catastrophic. So for neonates and pediatrics, there's no time limit for dressing changes, but for adults, it's 7 days.
Thank you so much. And I think that covered some of our other questions that did pop up there. So what I'll do is I'll thank you. And again, I'm going to thank 3M for supporting us today. Just for everyone in the audience here, there is going to be a survey that should pop up in your browser as soon as this webinar closes. Make sure to take a couple minutes just to fill that out if you don't mind. But with again, I'm going to thank you, Karen. We really appreciate you coming on and sharing your expertise. I hope we get to see you at some point in the future as well.
I hope so too.
Perfect. And for everybody who's on the line, you will be getting a certificate of attendance for this webinar. And again, the recording will be shared in the near future. So just in the next couple of days, expect some emails from NSWOCC, and we'll talk to you at the next webinar. Thanks so much, Karen, and thank you to everybody on the line.
Thank you, everyone. Take care.